I think one challenge that we have when we look at the long-term outcome of anatomic TSA is that there are some possible long-term confounding factors. Number one, when I was in training, we used some implants that didn't really allow that optimal reconstruction of the humeral head. Number two, the components at the time, like Dr. Kasam already mentioned, all poly, subject to oxidation, which we know is a problem, and typically with inline pegs that were smooth. We also did anatomic for all comers. So before 2004, the worst shoulder was getting anatomic because there was no reverse in the United States. And finally, we didn't really understand some parts of the planning that today we pay attention to, like inclination and 3D planning. But what I think is that now that reverse is being used for the worst shoulder, so we do B3 glenoids and really bad B2s, using, like John Levy just said, an anatomic reconstruction, typically with a stemless, plus high-quality polyethylene, plus planning and execution is going to make failure decrease over time, which I think is great news. There are many common failures of anatomic TSA, including subscap insufficiency, posterior dislocation, glenoid wear and loosening, late calf failure, humeral loosening occasionally, stress shielding, fractures, and infection. But the four that we really deal with in most studies are these four: subscap failure, glenoid wear and loosening, late calf failure, and humeral loosening and stress shielding. If you look at the data from the Australian Joint Registry, which I think is really powerful, you can see how the rate of revision after a stemmed TSA is about a little bit over 1% per year. So 5 years, 7%, 10 years, 12%, 14 years, 17%. And if you look into this graph carefully, you can see that the cumulative reason for revision